So, good day everyone. So, our assigned topic is all about lactational amenorrhea method and long-acting and permanent method. So, what is lactational amenorrhea method or LAM? It is primary by preventing ovulation or frequent breastfeeding temporarily prevent the release of the natural hormones that cause ovulation. There are three conditions that considered affected under the method. So the first one is the monthly menstrual has not returned. The second is the baby is fully or nearly fully breastfed and often day and night. And the third one is the baby is less than 6 months old. How effective is the The risk of pregnant is the greatest when a woman cannot fully or nearly fully breastfeed her infant. So, how is the lump used? So, the lump can't be started immediately after birth up to 6 months after childbirth. The client should breastfeed immediately within an hour. Here are the following points should be provided to the clients. Feed on demand whenever the baby wants to feed, and at least 10 to 12 times a day in the first few weeks after childbirth, and 8 to 10 a day thereafter, including at least once a night in the first month. Daytime feedings should not be more than 4 hours apart, and nighttime feeding should not be more than 6 hours apart. Some babies may need gently encouragement to breastfeed more often even at nighttime. Start another food at 6 months in addition to breast milk. At this age, breast milk can no longer fully nourish a growing baby. The client should plan for another method while the LAMP criteria still apply to continue protection from pregnancy. As you can see in the screen, the advantages and disadvantages of lactational amenorrhea method. The advantages of LAMP is universally available to all postpartum breastfeeding women. With the LAMP, protection from an unplanned pregnancy begins immediately postpartum. The LAMPs contribute to improve maternal and child health care and nutrition, breastfeeding, and warning practices. The LAMP serves as a bridge toward the use of other family planning methods. What are disadvantages of the LAMP? The effectiveness of the LAMP may decrease among mothers who are separated from their child for extended periods. Full or nearly full breastfeeding may be difficult to maintain for up to 6 months. So, who can use the LAMP? All breastfeeding women can safely use the LAMP, but a client in the following circumstances may want to consider other contraceptives method. Of course, kanang naay mga AIDS or HIV. O kana pong mga mama nga nagpatutoy nga naay gigamit nga mga other medication, and also kanang mga baby nga bagong gipanganak nga kanang naay problema sa kanang kanang mususo. When should the client switch from the LAMP to another method? Of course, the client can switch to another method anytime she wants while using the LAMP. A client is considered not pregnant if she still meets the 3 LAMP criteria. She can begin a new method with no for a pregnancy test, examination, or evaluation. To prevent pregnancy, the client must switch to another method as soon as any of the LAMS criteria or no longer applies. The family planning services provided should help the client use a new method before she needs it. A client who wishes to continue breastfeeding can choose from several hormonal or non-hormonal methods. What important information should be provided to client who choose to use the LAMP? Of course, the LAMP is a family planning method based on breastfeeding that provides contraception for the mother and the best nutrition for the baby. The LAMP can be effected for up to 6 months after childbirth as long as monthly menstruation has not returned and the client is fully or nearly fully breastfeeding. For optimum effectiveness, the LAMP requires frequent breastfeeding day and night. The baby should be fully or nearly fully breastfed. What is long-acting and permanent method or bilateral tubal ligation and vasectomy? What is long-acting and permanent method? Are one of the most effective types of modern contraceptives. These safe and most effective methods are performed in health facilities by specially trained providers. Proper consulting must be conducted prior to the surgical procedure because these methods are considered permanent. Female sterilization bilateral tubal ligation. What is female voluntary surgical contraception? It is a safe and simple surgical procedure that provides permanent contraception for women who do not want more children. The procedure is also known as bilateral tubal ligation. Involves cutting or blocking the two fallopian tubes. Although these sections also present endoscopic approaches to BTL, the standard procedure is manilaparotomy under local anesthesia with light sedation. We have here different methods of female voluntary surgical contraception. The first one is endoscopic method or laparoscopic tubal ligation. One of the popular methods of BTL with a success rate for preventing pregnancy in more than 99 out of 100 women. In preventing pregnancy, they use specialized tools called a laparoscope. The doctor is able to view the inside of the woman's abdominal cavity and block both fallopian tubes. With laparoscopic tubal ligation, a small incision or cut is made just below the umbilicus, through which a metallic tube called a trocar is inserted to assist the abdominal cavity. Through the trocar, the laparoscope is inserted, thus enabling the inside of abdominal to be viewed, the uterus and fallopian tubes to be identified. The fallopian tubes made then blocked with fallopian rings, cup, band, and suture ligation. Segmentally destroyed to electrocoagulation or be partially or completely removed. Through the most common types of anesthesia administered for laparoscopic, BTL or spinal and general anesthesia, the preferred procedure in the country. For keeping the client comfortable is local anesthesia with analgesia and sedation. Laparoscopic BTL is usually performed on an outpatient basis.
Hello everyone, so this is the continuation of Operator's discussion, so-called endoscopy. This is a type of vaginal sterilization procedure. The vaginal approach of tubal ligation was once the preferred technique. However, this procedure is associated with higher risks than laparoscopic tubal ligation surgery. Those surgeons have been favoring the transabdominal over the transvaginal approach. This is also known as transvaginal hydrolaparoscopy. Coldoscopy is considered to be minimally invasive surgery. A major advantage of a coldoscopy is that no abdominal incisions are made. Coldoscopy tends to be reserved for obese patients or for women with a retroverted uterus. Retroverted uterus, it is occurs when a woman's uterus or womb tilts backward rather than forward. So this transvaginal procedure involves a small incision made through the vaginal wall. However, a coldoscopy may be difficult to perform because it requires a woman to be in a knee-to-chest position while under local anesthesia. During the coldoscopy, an incision is made into the posterior vaginal fornix or the recess behind the cervix. A coldoscope, which is a type of endoscope with light that is used to visualize female pelvic organs, is inserted through the incision into the peritoneal cavity. The peritoneal cavity, it is the space within the abdomen that contains the intestines, the stomach, and the liver. Then the coldoscope aids the surgeon in locating the fallopian tubes. The fallopian tubes are pulled through the incision into the vagina. The coldoscope is removed and the tubes are closed off, tied, clipped, or sealed shut and put back into place. The incision is then stitched close. A BTL or bilateral tubal ligation by coldoscopy takes about 15 to 30 minutes and is performed as an outpatient procedure. Then next is hysteroscopic tubal ligation. So this is a transcervical sterilization device was approved by the U.S. Food and Drug Administration in 2002. This micro insert is known as Essure. It is placed hysteroscopically to block the fallopian tubes from within the uterine cavity. So the insert contains inner polyethylene terephthalate fibers to induce fibrotic reaction and is held in place by a flexible stainless and steel inner coil and an outer nickel titanium alloy coil. Then the device is designed to stimulate tissue growth in and around the insert to form an occlusion of the fallopian tube lumen. Then the tissue barrier form prevents sperm from reaching and fertilizing an ovulated egg. It usually takes 3 months before the tubes are considered effectively occluded. It usually takes 3 months before the tubes are considered effectively occluded with the completeness of the blockage, which is confirmed by a hysterosalpingogram. Hysteroscopic tubal ligation is the short-term efficacy rate of the method is equal to or better than that of the other sterilization methods. However, the long-term efficacy rates are still unavailable. This method is not suitable for future reversal. This type of device is not yet commercially available in the Philippines administration. Mini laparotomy under local anesthesia, bilateral tubal ligation. So when we say bilateral tubal ligation, it is the procedure is being done to both fallopian tubes. So BTL or bilateral tubal ligation by mini laparotomy under local anesthesia is the accepted standard procedure of the Department of Health or DOH. Local anesthesia is used because it is safe and allows the client to go home the same day. General anesthesia is riskier than the sterilization procedure itself. Correct use of local anesthesia removes the single greatest source of risk in the female sterilization procedures. That is general anesthesia. Moreover, women usually feel nauseous after general anesthesia, which does not occur as often after local anesthesia. However, when using local anesthesia with sedation, providers must take care not to overdose the client with the sedative. Through a small incision in the client's abdomen, a segment of both fallopian tubes is cut off or blocked. With disruption in the continuity of the tubes, the woman's egg cannot meet the man's sperm. How effective is female sterilization? Female sterilization is 99.5% effective with perfect and typical use. So there are advantages and disadvantages of female sterilization. So what are the advantages of female sterilization? So first is permanent method of contraception. A single procedure leads to long life, safe, and very effective contraception. Next is does not involve hormones. No changes in libido, sexual desire, menstrual cycle, or breastfeeding ability. It is an outpatient procedure. Nothing to remember, no supplies needed, and no repeated clinic visits required. Wow. Results in increased sexual enjoyment as the woman does not need to worry about pregnancy. Then next is no known long-term side effects or health risks. Then can be performed immediately after a woman gives birth. Then next is can be performed without any routine laboratory tests, blood tests, or cervical cancer screening. Then next is what are the disadvantages of female sterilization? First is uncommon complications of surgery. Then infection or bleeding at the incision site. Next is injury to internal organs. Then anesthesia risks, which are uncommon with local anesthesia. Then BTL or bilateral tubal ligation is a permanent method of family planning, and some women may regret the decision later. Reversal surgery is difficult, expensive, and unavailable in most areas. Successful reversal is not guaranteed. Clients who may want to become pregnant in the future should not choose this method. Family planning counseling is crucial. In rare cases, when pregnancy occurs, it is more likely to be ectopic compared with pregnancies in women who have not undergone the procedure. Then one of the disadvantages is the procedure requires an operating room setup and should be performed by a trained provider. Then physical activities such as heavy work and lifting heavy objects immediately after surgery are limited. The client may resume normal activities a week after the procedure. Then lastly is the method does not protect against STIs such as HIV or AIDS. So when we say STI, it is a sexually transmitted infections. The next is who can use this method. So female sterilization is safe for all women. Women can have BTL or bilateral tubal ligation even during monthly bleeding, as long as she is reasonably certain that she is not pregnant. Then no medical conditions prevent a woman from using female sterilization. However, some client conditions may limit when where or how the female sterilization procedure should be performed. WHO or World Health Organization medical eligibility criteria provide evidence-based recommendations based on clients' conditions and characteristics. And then, the service provider is encouraged to use these tools as a guide in determining the suitability of clients to the female sterilization procedure. So next is who cannot use this method, delay use in the following situations. So first is currently pregnant, then women who are 7 to 42 days postpartum. Postpartum women with severe pre-eclampsia or eclampsia. Then prolonged rupture of membranes 24 hours or more. Then puerperal sepsis, intrapartum or puerperal fever. Then the severe antepartum or postpartum hemorrhage. Then the severe trauma to the genital tract. And also the post-abortal sepsis or fever, hemorrhage or severe trauma or hematoma along the genital tract. And also have acute DVT or PE. So when you say DVT or PE, DVT means deep vein thrombosis, while PE is pulmonary embolism. And also the major surgery with prolonged immobilization. Then the current ischemic heart disease. And also unexplained vaginal bleeding prior to evaluation. And also the women gestational trophoblastic disease, cervical cancer, endometrial cancer, or ovarian cancer. Then also the current PID, the pelvic inflammatory disease, and also current purulent cervicitis, chlamydial infection, or gonorrhea. Then the current symptomatic gallbladder disease, and also acute or flare viral hepatitis, and also have iron deficiency anemia. Then the local infection. And also next is acute respiratory diseases such as bronchitis or pneumonia. Then the systemic infection or gastroenteritis. Then the last is a sterilization concurrent with abdominal surgery without previous counseling or due to infectious condition. Then my last topic is steps in conducting a female sterilization procedure. So timing of the procedure. A client can undergo female sterilization. So at any time that she is reasonably certain that she is not pregnant, except between 7 days and 6 weeks after childbirth. Next is immediately after childbirth or within 7 days if she has made a voluntary informed choice in advance. Then 6 weeks or more after childbirth is she abstains from unprotected sex or correctly uses a reliable method of contraception. And next is the immediately after an abortion within 48 hours. So that's all everyone. Thank you for watching.
Good day everyone. So in this video, I'm going to continue the report of Miss Almi Mingito. Before the procedure, you should instruct your client to not eat any solid food for at least 6 hours before surgery. But the client may drink clear fluids up to 2 hours before the operation. Clear fluids is the best example here is the water, but not those kind of soft drinks like Coke, beer, or those colorful drinks like that. But maybe Sprite, I'm not sure if the Sprite, because Sprite has one of the
example of soft drinks too. So I don't think Sprite is good in this kind of procedure. So hours before the operation, bath thoroughly and clean the belly, genital area, and inner thighs with before going to the health facility. Wear clean, loose-fitting clothing, not wear jewelry or nail polish. Bring a friend or relative to help her go home after the procedure. Ensure informed consent by reinforcing counseling to avoid regret and emphasizing that bilateral tubular ligation is a permanent method. Explain to the client the elements of informed consent written on the informed consent form. Checking that the informed consent form is signed correctly by the client. Assess client's sustainability for the procedure by reviewing her medical history to learn about her past or current health condition, including the medication taken within 24 hours. So, checking the client's condition is accordance with the HUMEC recommendation. Perform physical and pelvic examinations. Also prepare the client for the procedure. So, actual procedure. First is observe proper infection prevention practices at all times. Perform the pelvic examination to reconfirm earlier finding and to assess the condition of the uterus and its mobility. Give the client IV fluids. Fourth is insert the uterine elevator for interval cases to manipulate the uterus. This step is not performed for women who have just given birth. Fifth is slowly administered intravenous sedative and analgesia. Administer local anesthetic to intended incision site. 2 finger breadths from the upper border of the pubic bone for interval cases, and just below the navel for postpartum women. 7th, make a small horizontal incision from 2 cm to 5 cm in the anesthetized area. 8 is when the abdomen is opened, depress the uterine elevator to raise the uterus from easy identification of the fallopian tubes. 9th is tie and cut each tube. 10. Close the incision with stitches, apply antiseptic, and cover the wound with bandage. The last one is transfer the client to the recovery area. So after the procedure, observe the client for at least 2 hours. Discharge the client when her vital signs are stable and when she can tolerate food intake. Instruct the client to rest for 1 to 2 days and avoid heavy lifting for a week. Keep the incision clean and dry for 2 days because if dili nila nalimpyuhan, it might also cause infection kung dili nila limpyuhan ang ilahang samad. Then, avoid rubbing and scratching the incision for 1 week. Take analgesic if naa sila mga pain nga ilang gibang mati like for example fever. They should take paracetamol, methylamic acid for kung nagmulungol ilang samad or something like that. Then, avoid sex until it is comfortable for her to do so, which is usually 1 week after the procedure. Provide client with written post-operative instruction after. Follow up. So, instruct your client to return to the clinic for a follow-up visit 7 days after the procedure to ensure that her wound is healing well. At any time she has questions or problems. What are the complications? So be aware of the warning signals and possible complications that may occur after the female sterilization procedure. Immediately refer the client to the appropriate health facility when she experiences any of the following like high fever for in the first 4 weeks, pus or bleeding from the wound, pain, heat, swelling, or redness of the wound that worsen or does not subside. abdominal pain, cramping or tenderness that worsens, fainting or extreme dizziness. If the client thinks she might be pregnant with symptoms of a missed period, nausea, breast tenderness, and also if she has sign of ectopic pregnancy such as a lower abdominal pain or tenderness on the side, abnormal or unusual vaginal bleeding or faintness, indicating the shock. Counseling tips should be provided to a client. So sterilization should not be offered only to women who have had a certain number of children or who have reached a certain age. Each woman must be allowed to decide whether she will want more children or whether not to undergo sterilization. Female sterilization is permanent. Female sterilization is permanent. Thus, the family planning counselor must ensure informed choice. A friendly counselor who listens to a woman's concerns, answer her questions, and give clear practical information about the procedure. That will help a woman make an informed choice. Informed choice results in a satisfied user without later regret. Counseling must include the 6 elements of informed consent with the client decide to undergo. Female sterilization, she signs an informed consent from the proofs that the 6 elements have been discussed. 6 elements of informed consent. First is that temporary contraceptives are available to the client. Voluntary sterilization is a surgical procedure. The surgical procedure involves risk. Among the risks in the possibility that the procedure may fail. The effect of the procedure should be considered permanent. The procedure does not protect against sexually transmitted disease including HIV and AIDS. The client can decide against the procedure at any time before the operation is performed without losing the right to medical help or other service or benefits. So people who most likely to regret sterilization are those who are young, have few or no children, are not married, are having marital problems, have a partner who opposes sterilization, have just given birth or undergone an abortion. Although these periods are convenient and safe for bilateral tubular ligation, women undergoing the procedure at these times may be more likely to regret doing so later. Through counseling during pregnancy, especially during antenatal visits, and a decision made before labor and delivery help avoid regrets. Involving the client's spouse in counseling is helpful as spousal consent is now being required by the service providers. However, family planning service providers should ensure that the decision to undergo sterilization is voluntarily made, not pressured or forced by the client. What are the facts about the female sterilization? So, contrary to popular beliefs, female sterilization does not make women weak, cause lasting pain in back, uterus, or abdomen, remove a woman's uterus or lead to a need to have it removed, cause hormonal imbalance, can also cause heavier bleeding or irregular bleeding or otherwise change women's menstrual cycles, cause any changes in weight, appetite, or appearance, change women's sexual behavior or sex drive, increase the risk of ectopic pregnancy, and also cause prolonged soreness and weaknesses. So, key points of bilateral tubular ligation. It is safe and simple surgical procedure. It provides permanent contraception for women who do not want more children. Can be performed in a number of ways including through endoscopic procedure, but the DOH approved standard is by laparotomy under local anesthesia. Can be performed at any time that the client is reasonably certain that she is not pregnant. Is safe for all women. It is also permanent. Counselors must ensure informed voluntary choice to avoid regrets. If no pre-existing medical condition required, special arrangements laparotomy can be provided in maternity centers and basic health facility where surgery can be performed. These facilities include both permanent and temporary sites that can refer the client to a higher level of care in case of an emergency. That's all. Thank you for listening.